years, and I'm semi-retired now, and spend a lot of time talking about healthcare and other stuff. But this has been a passion of mine for several years. I've gotten into healthcare reform, and what you'll see at the bottom of the screen here on the right is PNHP. That stands for Physicians of a National Health Plan, and I'm a member of that. And they're certainly not paying me for anything that I do or this talk or anything. But as you can guess from from that name, Physicians for a National Health Plan is kind of where I stand philosophically on the question of healthcare in our country. And we're very lucky to have tonight Dr. Ed Weisbart joining us, who was really generous in providing these slides. He's made all these slides and has given a talk to my hospital, St. Francis Hospital, on this very topic. So Ed is not going to learn anything tonight, but he's going to be here to give some comments at the end because I know he's going to be worthwhile listening to. So let's start right in. Medicare Advantage versus traditional Medicare. A big question that Medicare recipients are faced with: which should I get? About half of us, half of seniors, don't even know the difference between it. And up until several years ago, I didn't either. When I went on Medicare, I then had to find out. And 74% of seniors oppose cuts to Medicare Advantage, but they don't even know what it is. And probably 100% of seniors oppose any cuts to Medicare in general. So everybody knows that they want Medicare around. Um, my goal is to try to educate you tonight, help you make a well-informed decision. Should you get regular Medicare or traditional Medicare, or should you get Medicare Advantage? Nowadays, Medicare Advantage is becoming increasingly popular. In 2010, only 25% of Medicare recipients had Medicare Advantage. Now it's more than half, 54%. Have Medicare Advantage, and it's going up. Why is it going up? Well, the TV commercials are probably the main reason. It is being heavily, heavily marketed. Marketed by who? Well, Medicare Advantage, of course, is a product of private insurance industry. Now, when it comes to what's better, uh, it's about the same. If you conduct a poll and say, do you like your Medicare, traditional or Medicare Advantage? Most people, say, yeah, that's good. Yeah, because Medicare is a wonderful thing. And Medicare Advantage is simply taking over Medicare, but um, managing the Medicare. But it's not doing anything that Medicare didn't. Not really. Let's go into a definition now, finally. Traditional Medicare, regular old Medicare. We all pay into Medicare our whole working lives, okay? We pay into Medicare. It sits in a lump sum called the Medicare Trust Fund. And from that, money is doled out to the doctor and to the hospital. That's how it works. Very simple. Since 1964 or 5, I remember when it came into being. There was a huge uproar in the country. Socialized medicine. The government is going to get involved in medical care. AMA was staunchly against it, and since then, it's proved to be, along with Social Security, the most popular governmental programs we've ever had. Highly successful. Medicare Advantage, on the other hand, is operates differently. We all pay into that Medicare trust fund, but then that money is turned over to the private insurance companies, several different insurance companies: Aetna, Blue Cross, United, et cetera, et cetera. Um, they then, um, uh, thank you. I'm getting rid of that screen on the other side. They then the insurance companies get the money from Medicare and then pay the doctor and pay the hospital. I'll come back to um, the details, but let's examine them a little bit more. Traditional Medicare, regular old Medicare. Almost every doctor and hospital in the country accepts it. It's a 20% copay. In other words, Medicare covers 80% of that care. 80%, 20% is for outpatient. 20% copay is not being paid by Medicare. So we've got to come up with that money somehow. Um, that somehow is what's called a Medigap policy, and it's virtually mandatory. You really should have that Medigap policy to cover that 20%. If it's $1 million hospital bill and they pay 800,000, you're on the hook for $200,000. I mean, forget it. So you have to have that. You really, it behooves you to get that Medigap policy. So then that takes care of that 20%, with a $1,600 deductible for a hospitalization. And by the way, traditional Medicare did not set limits on that out of pocket expense. So again, if that's $1 million hospitalization, you better have a Medigap policy, and then you don't have that. You're not on the hook for that 20%. And by the way, another limitation of regular traditional Medicare, there's no hearing, vision, dental, or prescription coverage. So again, you have to buy a Medigap to eliminate the co-pays and for this 20%. You still don't get those hearing, vision, dental, and prescription. It seems like, that's a big problem. And it's a limitation of Medicare. Lobbies made it such that they could only cover a part of it from Medicare's inception. And that's just what we have. Medicare could certainly be stronger, and hopefully in the future will be, but that's what we got, a great policy that covers 80%. Think of it that way. Um, and then this Medigap policy, well, you have a $257 deductible, but then no sky's the limit here. That 20% is taken care of. It eliminates most out-of-pocket expenses. It still doesn't add in the hearing, vision, dental, and prescriptions, but it has $159 average monthly premium. By the way, there are several different Medigap policies, and Medigap, remember, that's from a private insurance company. You buy this Medigap policy, and they sell different varieties. Plan G is for good. That's the best. I would say that's the most desirable one to have, because that really takes care of of everything that you'll need it to take care of. $159 a month is what you're paying here. Now let's go to Medicare Advantage. Medicare Advantage has a very low or zero premium. They really make it extremely attractive. It's theoretically required to cover everything that traditional Medicare covers, theoretically, but they can use roadblocks. Those roadblocks are medical necessity criteria, prior authorizations, and very restrictive panels, meaning not every doctor is on this. Remember, almost every doctor in the country accepts traditional Medicare. Here, the panel of doctors who accept it are much more narrow. If your doctor is not on that panel, tough. Then you either have to get a different insurance, Medicare Advantage policy, or you have to get a different doctor. But it does include these additional benefits. These are candy that they give out: hearing, vision, dental benefits. Even and as in addition to that, it has this prescription drug coverage that's called Part D. So remember what I had said, traditional Medicare really should have a Medigap policy. It should also have that Part D coverage. That's about $35 a month. So 35 a month there, 159 a month here. You have a $257 deductible, and if you have to go in the hospital, you have 1676. Theoretically, Medicare Advantage has all of those benefits, but as I shall show you, very, very limited. It's also very complicated. Each insurance plan has a different copay and different deductibles. And typically, they have a $5,000 out of pocket limit, Medicare Advantage now, so that they'll cover everything. But if you go over their restrictions, that you're only on the hook for $5,000 here. Now, with your Medigap policy, there's no $5,000 that has to be paid for stuff that traditional Medicare excludes. Let's keep going with this. So here's some of those extras that Medicare Advantage provides: the eyeglasses, dental, hearing aids, and fitness. In other words, silver sneakers, a variety of other things that are less typically covered by these Medicare Advantage policies, but they make it awfully attractive. I'm going to get all this, and traditional Medicare doesn't cover it. Such a deal. And that's how they've gotten to be so popular. But those advantages, those extra benefits are not quite what they seem, not at all. This is a good slide that shows on average what you're really saving when you have a Medicare Advantage plan in red and what you would have paid out of pocket with traditional Medicare. Let's say for dental. A patient who has a person goes to the dentist with traditional Medicare, they're going to have about a $250 per visit out of pocket that they pay. They don't have any insurance. That's typically an average of a typical dental visit. With Medicare Advantage, which is supposed to cover your medical care, your dental care, you're still shelling out $227. You save 23 bucks. Same thing with eyeglasses. You're saving $20. For hearing aids, $22. These are very, very minimal benefits that they're offering. They play them up, but in practice, they pay for very, very little. Medicare Advantage is a business, first of all. No, they are not the devil, okay? It's not evil. It's a business. And as a business, it must make a profit. It has shareholders it must think of. I mean, those are its basic raison d'etre, as all businesses are. They have to be profitable. How do they make a profit? Well, don't forget, Medicare Advantage takes in all of the Medicare money of the people who sign up for it. But then they introduce these prior authorizations. I'll go into them more, but let me list them first. Prior authorizations, in other words, you've got to get their permission to have certain services. They have narrower ghost networks, meaning the number of doctors who participate with each individual plan is much, much more narrow, even for the most popular Medicare Advantage plan. So it's not going to be everybody. You got to consult that and see if your doctor is on that list and stays on that list, and the hospital. Restrictions and limits on care. Now, traditional Medicare has restrictions and limits, but they're known, they're well known, they're not changing, they're not arbitrary, and they are not profit-based restrictions. Let me then say that these harmful are called harmful practices are stuff that we didn't used to have in Medicare. Now, with traditional Medicare, everybody knows what it covers. Doctors have been using Medicare for since 65. Okay, they know what it covers and what it doesn't cover. Most patients also know what it covers and what it doesn't cover. But traditional Medicare Advantage, those are a moving target. They have different rules that can change year to year. Um, as far as prior authorizations and denials, um, I can say that pretty much all of these categories, durable medical equipment, Part B drugs, hospital stays, lab tests, and so on, they all require some form of prior authorization. But, and that prior authorization is nothing more than a delaying tactic. In other words, 83% of those denials get approved when you appeal it. So what have they saved? Why did they bother to delay if it's going to be overturned 83% of the time? Because this is business and money, time is money. Okay, when you're talking about hundreds of billions of dollars, that 1 week delay translates into 1 week of investments earning money for the insurance company. They're in business and they know how to do this. So it's in their interest to even throw a temporary roadblock in your care. Traditional Medicare does require some prior authorizations, but those, first of all, are known ahead of time. We all know what they're going to be. You don't go to the you don't get cosmetic plastic surgery. Everybody knows that. You don't get an electrical wheelchair right off the bat. That's going to be denied 30% of the time, let's say. But 67% of the time, those durable medical devices are approved. And it can take a little bit of time to get them approved. But these are only three categories that are require prior authorization. Taking an ambulance to your doctor's visit because you couldn't get a ride. That's not going to be approved by Medicare, by traditional Medicare. Even so, if you can give a good reason why it had to be, 63% of the time that'll be approved. So that these are the rules that are known. We all know what those rules are. And almost never are they overturned. Once they deny it, it's because it's for a good reason. Whereas, remember, Medicare Advantage denies it. I'm just kidding. We're just delaying this. So they're holding on to their money for a period of time. Medicare Advantage beneficiaries receive less health care. Is that true? Well, we can prove that, we can show that with this slide. For example, lengths of hospital stay, 3.5% less for a Medicare Advantage patient. Nursing visits, 5% less. Physical therapy, occupational, speech therapy, home health aid visits, all somewhat less. Not a huge amount, but enough so that this money is saved by the insurance company. Remember, they have bills to pay, they have a business to run, and they have profits to make. Medicare Advantage does not have that. Traditional Medicare does not have that. These are business practices. They're not evil practices. This is a business. You want a business, you're going to get this. Now, here's something that really does impact our health: delays from diagnosis to treatment. I won't go over the details of this slide, but you can see in red there are longer delays from diagnosis of certain cancers between diagnosis and treatment, longer than 2 weeks. Now, does that really make a difference? Especially when you're only talking about what, 11% difference here. Here you're talking about a nearly 40% difference from it's for a Medicare Advantage patient. That person had to wait longer than 2 weeks, 75% of the time. You're talking about a lethal cancer like cancer of the pancreas that certainly can make a difference in terms of mortality. In addition, Medicare Advantage patients are less likely to be allowed to use recognized cancer centers such as Sloan Kettering and Beth Israel in Boston and so on. These recognized National Cancer Institute designated cancer centers are approved. There's restrictions on typical medical Medicare. They say no um, a certain amount of the time, but they say yes 3 or 4 times as often as Medicare Advantage. In other words, Medicare Advantage prevents you from using those cancer centers much, much more of the time. Again, that's a big savings. If they don't have to pay Sloan Kettering and instead pay a more local hospital, they are saving money by doing that. Higher death rates after surgery. They're small but definite differences in death rates after cancer surgery. Medicare Advantage in red, higher death rates. Not a huge difference, 1.5% here, but a difference. Okay, if it's your patient, if you are the patient, that's a tremendous drawback. Medicare Advantage corporations, this says game the payment model. That's an inflammatory term. They make a business decision. They have to make a business decision um, to stay in business. Medicare Advantage knows how to bill the government more for the patient's care than traditional Medicare does. How do they do that? A variety of ways, but one big one is that they upcode. In other words, a patient with a cold who happens to have diabetes and kidney disease from that diabetes, they will, but he came into the doctor for a cold and spends, 10 or 15 minutes in the office for that cold. It's a doctor who knows him. He doesn't need to take a great deal of time. Still, Medicare Advantage is billing Medicare as though those other diagnoses that a patient carries is taking up the time of that visit. He's having to use more of his expertise. That's gaming the system. It really is gaming the system. It's, I'm from New York. It's BS. It's not legitimate. Those extra subsidies add up to 83 to 106 billion dollars a year that Medicare Advantage is taking from the Medicare Trust Fund to pay for our health care. Illegitimate causes for taking that extra money. What could we do with that 85 billion? Well, if we didn't subsidize Medicare Advantage to the tune of $85 billion, we could cover these small things like hearing and vision. We could cover all of Part D, in other words, the Medicare drugs. We could then match the $5,000 limit that Medicare Advantage has before their catastrophic coverage kicks in. So that $85 billion could basically be going to healthcare rather than to an insurance company. It could improve the Medicare product. Look, how are you supposed to make a decision with all of this? Well, first of all, you need unbiased Medicare facts. I'm giving you facts tonight that I think are unbiased, but you know my philosophy on it. Um, pay for health care, don't pay for business insurance. Um, an extremely valuable website is Medicare.gov, by the way. Not only is it accurate, but it's user friendly. It has all of the answers. You compare stuff side by side, Medicare Advantage versus traditional Medicare product. 1-800 Medicare. They will tell you on the phone. Very, very accurate. Very good. They know how to. They know their stuff, and the main thing is you can trust what they're saying because they don't have the profit motive. They are not trying to limit anything, limit the care that you get, but rather telling you what is available to you, what the Medicare laws allow, and what help you a great deal the making your decision. I'm going to stop sharing for a second because I want to pull up another slide. hope everybody's still awake. I'm going to drafts.
John, do you mind me mentioning one thing while you're looking for?
Please go ahead.
We had a program with the Center for Medicare Advocacy, and they are located in Willimantic. They're a nonprofit, and if you are denied something concerning Medicare, they will fight for you. There are attorneys and
I've
paralegals.
heard of them. I've heard of them. I have
And
not.
they did a program for us. It's on our YouTube channel, but they actually have helped a few people that I know who we sent to them. They don't charge you anything and they seem to remedy the issues pretty quickly.
What is the name of that again, Mara?
It's called the Center for Medicare Advocacy, and they're located in Willimantic, Connecticut. And
Center
they're,
Medicare Advocacy. Everybody
yes.
remember that. That's very,
Yes, I'll put it into the
sounds great.
chat, but I just felt that everybody should know about it because they don't charge anything and the lawyers go to work for you.
I've heard of that. It sounds like a
Yes.
very valuable
Okay, thanks.
service.
Sorry.
Um, okay. I have an inflammatory photo picture here of Dr. Oz. We don't need to go into that. Dr. Oz is the current head of Medicare and Medicaid services. He's a doctor. Sounds good. Sounds like he's qualified. If you know Dr. Oz, you have you have a great deal of trepidation accepting his advice on such things. However, he's not ignorant about it. Dr. Oz ran for governor of Pennsylvania 4 or 5 years ago, and part of his platform was Medicare Advantage for all. Now, you know what I say to that, and for all, not only seniors, everybody, Medicare Advantage. I'd say he got it half right. Medicare for everybody, yes. Medicare Advantage for everybody, no. Um, Look, we can simply, I said that what my philosophy is here. Dr. Oz's philosophy seems to be that governmental agencies are not out to do you any good, that they are wasteful, that they are inefficient, and they don't, they waste money. Um, I think I've shown all the ways that Medicare Advantage is not wasting money. They're putting it to good use. Their own business and profit is what they're putting their money towards, while kind of and paying for our medical care, getting that money from Medicare itself. So they're in business. They know how to shave money off of the Medicare system and make it a profitable undertaking. If Medicare Advantage could offer all that Medicare, traditional Medicare plus Medigap, and I'll put those together. Don't get traditional Medicare without Medigap, and you have to get a Part D, but that's only $36 a month. So traditional Medicare plus Medigap plus a Part D to cover your drugs. You have um, uh, reliable coverage that's not going to be taken away from you, that won't change year to year, that won't exclude your doctor and hospital. I mean, this is the peace of mind that you need insurance for. Um, so uh, uh, for me, the choice is an easy one. You know, if Medicare Advantage could do everything that Medicare does without the subsidies from the government, that extra 100 billion or so, or 80 billion from the government that they're really not entitled to, I'd have no problem with it. But I'd also be shocked because Medicare Advantage is the insurance business. And as such, it must earn a profit for itself and its shareholders. Traditional Medicare is not a business. For those who believe that a governmental agency is always less efficient than a business, consider this. Private insurance, all private insurance, including Medicare Advantage, operates with a 12 to 18% overhead before health claims can be paid. That's overhead, meaning they have to hire a small army of of people to figure out how to turn these profits by denying, by delaying, and so on, and earn hefty, hefty profit. Medicare, traditional Medicare does not. It operates with a 2%, 2% versus 12 to 18% of these really trillions of dollars that are being spent on our health care in this country, $4 or $5 trillion a year, I believe. Um, so it's extremely important to keep that overhead down. Medicare has done that since its inception. Um, I'll simply say that Medicare Advantage was conceived. I remember when it was conceived. Hillary Clinton was all over this. She felt that this was a way of covering everybody in the country. Well, managed care never really got off the ground in this country. It was vigorously opposed. Medicare Advantage was conceived, though, around that time as an idea of improving care, giving better service, and saving money. It has done the exact opposite. It has not improved care. If anything, it's worsened care. It has provided worse service by being much more complicated and having barriers to timely care, and it's cost more money. You know, getting back to the choice of which to get, you could accept the inducements of the private insurance companies to join Medicare Advantage. Zero premiums. You have one card covers everything, right? Free silver sneakers, and free benefits towards dental, vision, and hearing, but they're, pathetically small benefits. But, they're inducements. But you must also accept its negatives, the limited and changing network of doctors and hospitals stalling prior authorizations, an average of $5,000 maximum out-of-pocket payments. You could instead get traditional Medicare with Medigap and a Part D, meaning drugs, and you have stable insurance with benefits you can always count on, and you'll know what they are. They're the same as they've been for a million years since Medicare started. So I can tell you, by the way, that I hope you all have a trusted insurance agent. And if you don't, then you go to Medicare.gov. And if you encounter problems, consult the service that Mara Whitman has just told us about. Mara, mention it again before the end of the evening, because it's important for everybody to take that down in making your decision. And before I ask for questions, I'm going to ask Dr. Ed Weisbart, who knows this way better than I do, to please weigh in and make some comments if you have any, Ed.
Sure, yeah. Thanks. Nice job, John. That was
Thank
it's
you.
fun to watch you doing this. So thanks for this. Um, I guess the biggest thing I would say is that I agree with your position. You know, obviously that Medicare Advantage uh, costs the country more, doesn't protect people, actually hurts people. But it I think we do need to bear in mind that they because of the way they're so overpaid. Um, they've set up a system where some people are just simply trapped in Medicare Advantage. You know, I'm a retired physician. I can afford the $160 for Medigap. I can afford the drug benefit. So I spend maybe a couple $1,000s a year so that I don't have to worry about copays and deductibles so that I have a pharmacy benefit. But I am a retired physician, and there are a lot of folks for whom that $2,000 or more a year you can't afford not to you just can't afford it. So so what a lot of people do is when they turn 65 they think, well, golly, I listened to Dr. Cappadona. I've got to spend a couple $1,000s a year so that I have Medigap and a drug benefit, or for free I can go into Medicare Advantage. I'm going to go for free into Medicare Advantage. And then, I'll save that $2,000. And maybe a couple, 3, 5, 10 years from now, when I run into some of the problems that he was talking about, then I'll go back to traditional Medicare and buy Medigap. And so The one thing I wanted to say is that people need to know that they're trapped in Medicare Advantage. If you just turned 65 and you want to buy Medigap, the Medigap insurance company has to sell you a policy and they can't ask you about your health. But if you've been in Medicare Advantage for 12 months and then you want to go back to traditional Medicare and buy Medigap, there's no guarantee that you can get it. The Medigap insurance companies have to sell you a policy at the same price to sell anybody else for the first 6 months that you're in Medicare or 12 months in Medicare Advantage. But if you've been in Medicare Advantage for 13 months and you run into these prior authorizations and you're worried about your health, so you want to go back to Medicare and not have those prior authorizations, you need to really be careful and find out if you can get Medigap. You might not be able to. That protection disappears from Medicare Advantage, from Medigap. So just a thing to bear in mind. But nice job.
And thank you, Ed. It's a very important one, and I left that out. That's huge. You can sometimes get into a position where you can't afford what you need to get. You cannot get that insurance that you need because, Obamacare supposedly eliminated this pre-existing condition criterion that could be used by insurance companies, but not for Medicare, except for the first 6 to 12 months. So don't get sick after that point and be stuck with your Medicare Advantage policy. That's why, figuring this, if you can afford it or not, um, they have you trapped. It's really an unfair inducement um, to buy their product because you could be trapped with significant medical bills. At this point, I'm going to ask for questions. And
We
Mara,
have somebody that raised their hand, and I can't remember who it was, but if they want to unmute and ask their question, and then we have a few things in the chat, but I know someone did raise their hand.
Senator, oh, good for you, Senator Medicare Advocacy.
But we do have a question. We have some comments from Jeffrey. I don't know if he'd like to speak. And also, Shirley has a question. Would you like me to read it?
Please.
Okay, Shirley asked, do both traditional Medicare and Medicare Advantage require that your PCP have admitting privileges to a hospital where you want care? Should this determine which PCP you choose if you've never been hospitalized and you do not expect to be? Good question.
Oh, yes. And the answer is yes, it does very much matter. You have a certain doctor and then you have a certain preference for a hospital. Now, usually, if you selected that doctor, you've known that where that doctor is affiliated, where he's on staff. You need to find out that both the doctor and his hospital of affiliation are members of that Aetna, United Healthcare, or whatever Medicare Advantage plan. Or you can't use them. So this is what people will typically do before signing up for a Medicare Advantage plan. They'll consult the list of participating doctors and participating hospitals. And those, they can change. Dr. Weisbart, one of his slides mentioned a ghost network. In other words, he used to be on this panel, but he isn't anymore. So you must be very careful, and these things can change. Like I had said, my hospital lost its affiliation with United Healthcare. And I knew it was going to pass, but it was 3 or 4 months before that was settled. And those patients who had United Healthcare and were our patients could not get care at our hospital. I mean, that's huge. Can you imagine? So these exclusions make Medicare Advantage, as far as I'm concerned, very, very undesirable. I hope that answered your question.
Jeff, Jeff Atwood, would you like to comment or ask any questions? I know you've put some information in the chat.
Jeffrey, would you like to speak up? You have a I'm reading in the chat. It's a it's a very, very long question. So I wonder if, well, here's what I'm going to try to do. Jeffrey had said, Americans deserve what every other Western government delivers, health care for all, cradle to grave, no one goes bankrupt. And that's largely true. What can I say? We are behind the curve on this, extremely so. America, the United States is not the same as Western European countries. They've taken a different tack. Um, um, remember, if you want to call what taking place in those countries socialized medicine, Medicare is every bit socialized medicine, if you want to make that point. And nobody, Republican, Democrat, or anything else, would trade their Medicare for anything else. So, yeah, don't use the S word, the socialized medicine word. It doesn't have any meaning after a while. I mean, our government can give benefits to all of our citizens, not only health care, police protection, fire protection, public schools. Is that socialized? Well, I guess you could call it that. But I believe that's what Jeffrey was saying. We deserve.
His mic is not working, but he did ask another question, and then we're going to go to Cortland Wilson.
Okay.
Let's just do this question first. Jeffrey said we spend twice as much per capita as the next most expensive country, Canada. Why? And then we'll go to Cortland.
Well, I'll say I've researched this myself. Good, as a good point. You've done your homework too. Yes, we do spend much, much more per capita. Not only that, but we have worse outcomes. Our life expectancy is lower. Our infant mortality is worse. I mean, we're paying so much more for poorer results. You say, well, the United States is different than those countries. It certainly is, but that's one way it's different. Our approach
People aren't any different.
Yeah. In any case, I think you get what I'm saying. Yes, I happen to agree with you, and I hope that one day this will be a reality where everyone has Medicare, but it isn't now. And our decision now is, at least for those Medicare recipients, Medicare, traditional Medicare or Medicare Advantage. That's something that you can vote for right now with buying a policy or one kind of a policy or the other. Now, I think
Let's go
Wilson.
to Cortland Wilson. Thank you for your patience, sir.
Hi, it's actually Jane. Hi, John.
Hi, Jane.
So I know that doctor offices have to spend an inordinate amount of time sometimes trying to get approval from the insurance company before a test or treatment may be given. Are doctors more aware now of those treatments that may be denied and therefore may go forward in choosing the path of least resistance and choose a less expensive and thus less effective test or treatment for their patient just to save that time?
I would say, yeah, we all do that. We all say, that's not going to be covered. Let's go with this first. And I can say, without saying all doctors are above putting their own convenience before the health of their patient, that the big problem here is making a doctor jump through the hoop to get that prior approval, or saying to the patient, look, let's go with this. Your insurance probably won't cover it, but I think it'll be just as good. Now, as far as affecting a patient's outcome, I would hope that we don't adversely affect patients' health by choosing that path of least resistance. And I can say truthfully, I've had to negotiate with insurance companies my whole 40-year career. And we found a way to make it work, But we all resent having to dance to the insurance company's tune. They've decided what the best treatment is. Can I make that work? I'll find a way, But I mean, it's them making the decision, non-doctors making that decision, which, is really regrettable.
Thank you.
For
Go ahead.
Shirley, to clarify regarding PCPs and hospitals, if your PCP is not affiliated with the hospital where you would want care, but both are in network for your insurance, could you still use that hospital?
You can use that hospital, but that doctor won't be accepting your insurance. So he would have to kind of turn your care over to a doctor who's on the staff of that hospital who does accept your care. So it makes it very unwieldy. I mean, you'd really want to avoid that. I can tell you that nowadays it's less of a problem because of hospitalists. Hospitalists are doctors who don't have office hours, they are in the hospital, and your doctor may not go to the hospital anyway. Your PCP, a very good chance that your PCP doesn't go to the hospital nowadays. Probably more than half of PCPs don't treat their patients in the hospital. It's because they're hospitalists. This is something that's independent of Medicare or insurance and stuff. It's doctors' use of their time. It's very inefficient. It was always very inefficient for me to go to the hospital to take care of one patient who had pneumonia, where it's 45 minutes to Hartford Hospital, 45 minutes back. I have an office full of people. There's one patient in the hospital. It was very, very inefficient. So they came up with hospitalists probably for the last 30 years. And I have to say, I didn't think of myself as a real doctor if I didn't go to the hospital, but I got over that because it is just too much. It was just too much. It made for an unmanageable day. And it's not that I'm giving expert care or anything. I'm there because I know the patient and I can comfort them throughout their pneumonia and so on. But the hospitalist is taking care of your pneumonia at least as well as I would. But it's a discontinuity of care. You're right. Then he or she has to turn the patient back over to me after the hospital. But that's not a question of Medicare or anything. That's just how medicine is nowadays.
I put in information, Dawn Cooper Grodger, she's a social worker at the Bloomfield Social Services Office. And she is trained to help people decide on these kinds of questions and
That's
what
great.
plans.
Bloomfield Social Services. Oh,
Yes, and as
you
long as
put
you're a
that phone number
resident,
in the
I
chat.
will.
Great. And you did
Um,
put that contact of Center for Medicare Advocacy, I believe,
yes, I did. I
at the
did.
beginning of the chat. That's good.
Yes,
That sounds like it'll be great.
yes.
Any
So,
more questions, anybody? Okay, if not, then I'll thank you all for coming. I hope you learned something. I'll simply say good night and good luck to everybody. Mara, thanks so much for your help. And Dr. Weisbart.
oh, we have another question.
Oh,
Walt
got
has
another
a
question.
question.
Okay, another customer. What do we got? Can you read the question, Mara?
He raised his hand.
Okay.
Oh, he raised his hand.
All right. Can you hear me?
I can, yes.
Okay. Hi. Walt Zaplinski here, and thank you for your presentation tonight.
Thanks.
I had a question I typed into the chat, but for which calendar year is your pricing data for the Medicare Plan G and for the Medicare Part D premium?
Ed?
Yeah,
Is it-
it's 2025 data. The Part D actually probably a little bit higher than what Dr. Cappadona was saying. The Part D premiums are now more about $50. There was quite an uptick for a variety of reasons. Their Part D premiums, I think, are averaging 50, but the numbers on the average premium for Plan G supplemental, that's 2025. But they're all averages.
Yeah.
Really apply. So you want to know the price, you need to go to Medicare and
Okay.
top the price.
Right. Well, thank you for sharing that because we're looking for something to compare our group price for. It's all lumped together. We get a package deal. And so we're trying to figure out if it's fair or not. And without knowing the component parts of the medical, the prescription drug plan, and that it makes it difficult. So I thank you for the information. And the source, you said these were kind of like average prices.
Yes.
And the source that you used for them, or multiple sources?
I've it is on the slide. So
Um,
I don't
I'll
have the
tell you
deck right
what,
here.
if you, I'll get that, I'll get that
Okay.
reference
Yeah.
for you. If you will send me an email, Cappadona at snet.net, snet.net.
Okay.
But understand those are national averages, and so
Yep.
if you're actually making a local decision, what you
Right.
might want to do to have it be more relevant to the decision is just go to Medicare.gov and look at them. They're right there with prices. So
Okay. Okay. Thank you. I appreciate that very much. And thank you for the work you do. We followed PNHP for several years, and I thank you for what you're doing, and I share your work with my providers as well.
Great.
thank you.
That's good to hear. Anyone else have a question for us?
There's a comment from Mary. Lots more retired folks need to hear this presentation. They too often opt for cheap. Hearing from you may help them realize you get what you pay for. Thank you for taking the time to help everyone. Now, I just want to say for the library that Dr. Cappadona and Dr. Weisbart, you know, you're volunteers and you took your time out to help everybody. And this is going to go on YouTube to help more people, but it's wonderful that you are here to help people.
Thank you for that. And yes, it's a service that we provide, because we're at a certain point in our careers where we can where we want to do this and can. And I'll be if any of you have a group that you would like me to speak to locally, I will. This isn't the first group I've spoken to. So
yeah, and if anybody doesn't have John's email or needs to reach John, they can contact me and I will send you on to John.
that's nice. I'll even give it to you now. Cappadona at snet.net, snet.net, and Cappadona. If there's no other questions, we're gonna call it a night. Thank you so much.
Thank you very much, and everybody have a wonderful night.
Good
Take
night,
care.